My presentation is about how will COVID-19 impact fertility in 2020 and especially 2021. I have a lot of material that I want to cover here, so I'm going to try and move quite quickly. So we have, of course, this story that circulated. I'm sure you saw it. I have just one example here from the New York Times of corona babies, that everybody's going to be cooped up together and they're going to make a lot of babies. So this is sort of a story that circulated in the media. Of course, as I think is probably pretty well understood in this audience, that is unlikely to be the reality. We have decades of research showing that after a high mortality event, births tend to decline. So maybe one of the first clear demonstrations is in 1969, but I think the classic one is probably Ronald Lee's 1981 study of 300 years of English data. But we have a lot of different papers showing this general decline in births after a high mortality event. So the first question that I'm going to tackle here is this really general? Yes, we have some papers showing this. Yes, this is something we think happens, but is it really all that general? Is it so general that we should expect it after COVID and have a high degree of confidence in that? But my second question is perhaps even more interesting, and it's where I'm going to spend most of my time in this presentation. And that is, if this is really general, if this is something we see very broadly across high mortality events, why? Why do births tend to decline after high mortality events? So there are a lot of proposed answers for this in the literature. One big family I'm calling direct or even biological effects. We get things like arguments about caloric shortfalls leading to amenorrhea, fetal loss or miscarriage, the death of reproductive age women, all these things that would quite mechanistically reduce births. Then we also have indirect or social effects, things like reduced sexual activity, the death of partners, or even more termination of pregnancies. But one I'm particularly interested in is the possibility of deliberate delay. Delay, postponement. These words, of course, have different meanings, but what I mean by this is simply individuals consciously avoiding conception during and immediately after a high mortality event, and then engaging in some kind of catch-up in some future period. So there is a lot of research out there suggesting that this happens. I have a few examples here. The key to all of these examples is that they are all from relatively high fertility, low life expectancy societies. That is, they're all from, quote, pre-transitional or mid-transitional societies. So we've observed a lot of cases where it kind of looks like there is postponement. That is, births fall in the immediate aftermath of a high mortality event, and then they seem to rise in subsequent years. And this is consistent, so these researchers argue, with postponement or delay. The problem is these cannot directly observe fertility preferences. Maybe it's delay, or maybe it's something else that just happens to look like delay. Without directly observing the intention to delay, it's difficult to prove this mechanism. So that's what I want to do, is prove it. The first step is to confirm the generality of the relationship between high mortality events and subsequent birth declines. So I've combed through archival records of high mortality events, disasters, epidemics, just a cavalcade of bad events. And then I've matched them where we have vital statistics data, and where we don't have vital statistics data, I've attempted to find substitutes. So for example, I use church and parish registers for a number of yellow fever outbreaks in the 18th and 19th centuries. So what we get here along the x-axis is the increase in deaths during a pre-identified high mortality event like a disaster or an epidemic. And along the y-axis, we have the change in births 9 months later. It's pretty noisy. It does seem vaguely negative, the relationship, but it is quite noisy. Now, I have separated here epidemic diseases from disaster and war. And what you'll notice is the relationship between disasters and wars is much noisier than the relationship with epidemic disease. So focusing on epidemic diseases here, I've categorized by different kinds of diseases. the relationship is a lot clearer. These dark blue dots, you can see, this is 1918, the 1918 influenza pandemic. So there's an extensive literature on that, but it falls well within the relationship we observe from epidemic events more broadly. But this might not be a good method of approaching this problem, because we've pre-identified things we already think are valid high mortality events. They're disasters, they're diseases. So I also use the complete UN database of monthly vital events to search for high mortality events we might not already know about. And then I build a panel model for each country and event, identifying how births change around that event. And we do see one of the only significant effects is 7 or 8 months after the event, there is a decline. And then about 12 to 14 months after, there is an increase. It is surprising that it's not 9 months after the event. There are a large number of countries in this database that register month of death with a delay. That is, they're not actually reporting date of death to the UN, they're reporting date of registration of death. And that may be accounting for some of that. So more deaths does seem to lead to fewer births about 9 months later, approximately. So did COVID increase deaths? That's the question. Of course, we know yes, but here I have excess mortality for a large number of regions, all US states, Canadian provinces, every country that reports to Eurostat, 5 Latin American regions, and 8 regions in Asia. There's variation, but you can see these are large mortality increases. Generally, I identify a high mortality event as a 20% increase in mortality. We have some here that are over 100% increase in mortality. So yes, COVID is a big mortality event. So will births decline? And here we want to look at fertility preferences to see if this deliberate delay mechanism shows up. US states are a great case to do this because they've been hit at different times with different spikes in mortality, and some have been hit by multiple waves. So there's lots of variation to use in a model. So I ran 2 waves of a survey of fertility preferences, one in April, another in September. I'll be running another in January and another in May. We have about 1,300 reproductive age women in each sample. And we asked them an extensive battery of questions about fertility preferences, experiences of COVID, public attitudes, social attitudes, their economic experiences, these sorts of things. And then I analyzed this at 2 different levels, the individual level and the state level. So at the individual level, we're just looking at whether the state level excess mortality before a survey wave is associated with individual expressions of intention to delay or personal fertility ideals or intentions to have another child, these kinds of things. I use either OLS or LOGIT depending on the structure of the dependent variable. And then of course we have the usual battery of controls, and I have some robustness tests, but I want to move on to the state model here. Moving up from the individual model, I also look at the state level, the prevalence of delay intentions, the prevalence or the average personal fertility ideal at the state level. How do these relate to mortality rates? And using the state level actually allows us to use a panel model because we have all the states in both waves. Almost all the states. We have, like, Montana has very few respondents, so they get dropped. So first we have our individual model. First, as just a validity check, we can see that mortality experience is significantly associated with the odds that an individual is worried about COVID. That's a great sign. It suggests that mortality is probably a valid indicator of the experience of COVID. Our effects are very noisily estimated. Our sample sizes are not that huge, and we only have 2 waves. But the most significant ones are that the odds that a woman reports that COVID led her to reduce her desired ultimate parity are much lower when death rates are higher. Now, this is going to sound strange, but what this is saying is that women are less likely to revise their parity desires downwards when death rates are high. Now, we also have an extremely imprecisely estimated decline in the upward revisions. It's very imprecisely estimated, but what we're seeing is that when death rates rise, in fact, the odds that people change their parity preferences fall. They become more fixed in their preference. We also see that general fertility ideals rise. Those are significant effects. We also have some insignificant effects, but I want to point to them as a matter of direction. The odds that a woman says that she is delaying, that COVID led her to delay, are higher when local death rates are higher. It's not highly significant in this model, but directionally it is what we would expect. There's more delay. We see this small and extremely imprecisely estimated decline in self-reported eagerness to have children. And we see this small increase in the number of months until the woman expects to have her next child. But these are not significantly estimated, but they're interesting as a matter of direction, because when we turn to the state model, some of them become significant. At the state panel level, where we're actually catching change over time at the state level, again, we see this relationship with COVID worries. We see this strong relationship with parity desires that's similar. Our delay effect becomes significant. So higher death rates lead to more women saying that they are delaying childbearing. And then we actually have significant effects for both personal and general fertility ideals. And then our expected months until next childbirth almost becomes significant. Of course, I would like it to be significant. It isn't quite. But again, our sample size is simply not that large for the degree of variation we want to get at here. But generally, this is consistent with what we would expect.
2 minutes.
So when state level deaths rise sharply, long run desired parity tends to rise. There's variations depending on exactly how we measure it, but it tends to rise, consistent with mortality replacement things. And there's an extensive literature on these long run effects, looking at the Indian Ocean tsunami, Hurricane Katrina, loss of children, loss of siblings. But as death rates rise, more people also report delays, and the timeline for intended births appears to shift outwards. This is exactly what we would expect based on the wider literature. This is exactly what the wider literature has suggested we would find if we could measure fertility preferences during a high mortality event. It just so happens that the successive waves of COVID in the United States provide an opportunity to measure that, and we do in fact find what the prior literature suggested. So why do births generally fall 9 months after high mortality events? Because people choose to delay. There may be other effects working as well, but definitely the delay effect does exist. Now, we can also consider the robustness of this. I'm not going to go too long on this. There aren't actually a lot of other cases where we can measure this. One of the only ones is the continuous DHS program that was run in Peru for a few years, but the only high mortality event in that sample is an earthquake in Ica on August 15th, 2007. It's actually not a very large death spike. In total, it's a catastrophe, but it wasn't a very large percentage increase. But I went ahead and looked at the waves with about 1,000 respondents before and after that earthquake in Ica. And DHS asks about the expected number of years until the next birth. So we can see in the rest of Peru, there was no change pre and post-quake. Whereas in Ica, immediately pre-quake and immediately post-quake, there was a significant change in the number of years expected until the next birth. So this is the delay preference. We can then look at other disasters, and we can look at mean ideal family size for the long run. And I think I'm about out of time, but I'll say that I tested this in the 2004 tsunami, the 2003 European heat wave, and the 2010 Haiti earthquake. And in all three cases, we do have a long run increase in fertility preference, in long run parity desired after a high mortality event. Thank you.